talk today is about the journey that we've been on for the last probably 10 years, but 6 years actually live. We started at the end of 2013 with a really small pilot, and I just want to really give you some insight into how you can actually turn what is amazing theory into practice if you have the right technology and, most importantly, the right people, because at the end of the day, all this amazing research and everything that we're doing has got to keep the people that we're serving, the service users and the patients, at the very heart of it. And also to say that you will come up against barriers as you go on this journey, and some of them are around things like information sharing. Just to say that I think more people suffer when information isn't shared than are adversely impacted when information is shared. And so if you focus on the small steps and just keep going, you'll eventually get to the top of the mountain. So in case people don't know, this is the current situation around interoperability in England. Interoperability just means joining together different systems and sharing the information. The red areas on the slide are where there isn't anything happening, and the blue areas on the slide are to show you where there's 3 or more systems talking to each other. So we don't really blow our own trumpet very much with what we are doing in Connecting Care, but actually we've got 19 different systems and we've got 23 different organisations having a look. So we are actually ahead of the game here. When we started in our area, there were only 4 programs running, 3 running and then us. And people were still recovering from the national programme for IT, which had been very much top-down, one-size-fits-all. I don't know if anybody lived through those days. I did, and it wasn't. Well, it was a test. Let me say that. So by the time that we get to today, you can see that actually the direction of travel has changed, and people are realising that if you do things locally, you can actually achieve a lot. And I think that is also now the direction of travel from the centre and from the government. I'd be really interested to hear what Matt Hancock's got to say this afternoon about that. You know, this is the right thing to do. Sending information via post and getting people to use telephones is just not the way to go. We've got to work smarter, and so we need to get ourselves joined up. So again, I know that you won't be able to see everything on this slide from the back, but just to say that along the bottom here are the source systems. So there's not duplication. People just write into their own system where they're working. Those organisations are the data controllers. They decide what they want to share, and that is agreed. If one of the partners wants to share something more, then that goes to our information governance group. It's discussed, everything's documented, including decisions and why we've made them. In the middle is is where the magic happens with our partner organisations, Orion and NextGate. So NextGate have an electronic master patient index, because as you can appreciate, not everybody who's in social care and other areas use the NHS number as the primary identifier. So you have to make sure we get the right person. The design of all the different bits of information is done together with input from our users, so clinical and non-clinical users, and Orion Health, who run our big Rhapsody integration engine, sort out that design. At the top, got some people here. They are almost exclusively staff. We do also have some patients accessing now, which I'll talk about in a minute, but the staff have role-based access. So if you are a secretary working in social care, you don't need to see everybody's medications. It wouldn't be appropriate, you wouldn't understand it. If you're a clinician working in the emergency department, you need to see absolutely everything. We also, in that middle layer, have a clinical data repository where we have some clinical information stored, and we also have our display of documents area. And across the top, we've just got some other information about what you can see in the portal. Also, the very first box there is about security and privacy, because we do take the fact that we are looking after people's important information incredibly seriously. And you can also see there something about document delivery. So we are also able to take discharge summaries from our acute hospital partners here and send it to our GP partners here directly into their workflow, into their system of choice. So it can either be their EMIS or TPP or whatever system they've got running, or it can be into their DocMan hub, because anybody in GP world will know those are the sort of key players from the technology point of view there. And then very recently we've also had some patients who are able to access via personal health records some information and share that with staff. I'll talk about that a bit more. But it's more than just a portal. The way that we've gone on this journey is we've incrementally introduced enhancements according to what our users have asked us for. So one of the first things we were asked for was the ability to display documents. So we would prefer to show structured data, but as everybody here will understand, there's an awful lot of paper flapping about across health and social care. So we are totally committed to using standards so that we do things once and share. So we use XDS for display. Next thing was that the GPs wanted to have sight of the discharge summaries as soon as possible. So we put an electronic metadata wrapper around the documents at the acute hospital, and that has an intended recipient in that metadata wrapper, which means that it knows that it's going to be displayed in connected care and then onwardly transmitted to GPs. We're currently doing that across Bristol, North Somerset and South Gloss, but we're just going to be starting next month going out to GPs in Somerset, and then we hope to use a national system called the Mesh to actually do that across the whole of England, because as you can understand, people do come into our area, get treated, but they might be on holiday, so their GP needs to know, and their GP might be somewhere in Leeds or London or somewhere different, so we need to be able to send to them. Then the next major area that we're looking at is personal health records. So we've got about 5 projects in flight, including one with major trauma patients at North Bristol Trust, so that people don't have to keep reliving what's happened to them. If indeed they can even remember what's happened, they can take this with them on their phones. We are also using FHIR standards, so fast interoperative health resource standards for sending messages, and we did a piece of work where we noticed there was a gap between people getting controlled drugs on paper prescriptions before they were registered with the GP. So people who are homeless, people coming out of prison, that sort of thing. And that cohort of patients are quite clever at finding out where they could get the drugs from and trying to make sure the GP didn't know what was going on. So we've managed to plug that gap by using some FHIR messaging. And of course we've always got our eye on what's coming next, because it's an ever-changing landscape, socially, politically, etc. And we've got great hopes for the LICRAs to help deliver the infrastructure that we need to roll this sort of programme out more widely. Talking of which, because we are at the cutting edge of what's going on, we do get involved with some groups which are national. So on the document sharing piece, our team wrote the book on the standards for document sharing. Everything is open source. We have very good relationships with the other interoperability programs in our area, but also around the country. And I have a monthly call with those other interoperability programs that I showed you at the beginning, with the engagement leads, because it's really nice to have a sort of safe space to be able to just offload when you've been dealing with particular issues, and we all face the same problems. And it's nice to hear, you know, a solution from somebody else who's already been there and done that. So that's like a little support network that we've got going on for each other. Obviously, it's not all about the technology. It's about delivering things that people find useful and easy to use. And there was a lot of talk yesterday about that, as Brian referred to in his introduction. So really, it's no good coming up with a bit of technology which is all singing, all dancing. It's essentially, you say, what is the issue for people on the ground? What is the problem that you're trying to solve? And then use the technology to help you with that. So this graph is trying to demonstrate that as we've introduced these incremental enhancements, it has actually had an influence on the people who are out there and able to access the system. So there's usually a little bit of a time lag, but things that we've introduced, like our end of life record, which is the first stage of that journey, and we've got an agreed template with all our GPs. They're the single source of truth for that, and people at other palliative care settings will input and let the GP know what they've done for it to be updated. The in context launches from our supply system, so somebody working at an acute hospital or in a GP surgery or in the community, they just have one click and they get through into the same person in connecting care, and that will then open up all the information about mental health, about social care, out of hours, ED attendances, all those things. So whatever we can do to reduce the number of clicks and make it easier for the people who are trying to care for people and record how they care for people, that's where we like to work. So when we started, we had some key partners. So the 3 acute hospitals in our region, the 3 community-based providers, the Mental Health Trust, out of hours, the 3 councils, and the GPs. When we began, there were over 100 GPs. I think it's now down to about 85. And those 19 founder partners are all sharing information from their systems, but there are so many other smaller organisations who benefit from being able to see what's happened in those big places, that one of my roles is to find out who they are, where they are, and organise for them to get access to the system. And the most recent organisation that's joined in with us is the NHS Blood and Transplant Service. I didn't realise, I don't know if you do, that if somebody has said that they want to be an organ donor, that team, they're called the SNODs, which is the Specialist Nurses for Organ Donation. They have to double check to make sure that everything about that donor is okay, and they do that by getting notes faxed from GPs or phoning them up and getting information posted to them. So woe betide you if you need to have an organ donation out of hours or over the weekend. And just before Easter, I got the first team on to the system, and the first potential donor that they pulled up, they were able to see the letter from the oncology department at UH Bristol, which said this person is now free of cancer, and that meant that donation could go ahead. So over the Easter holiday, I think probably 5 or 6 people had their lives saved, or something amazing happened. And if they hadn't had the chance to look at Connecting Care, that would not have gone ahead, because there would have been no way for them to check what the status of that donor was. And that was a gap I didn't know existed until about 3 months ago. Yeah, so working with all these different organisations, it is a bit like trying to do a Rubiks Cube with boxing gloves on, because you don't actually have any direct influence over the people in your partner organisations. They've all got their own competing priorities, and all the people who are working in mental health, social care, and in the NHS are really under the cosh at the moment, trying to make their own savings and trying to achieve their own targets. So it's very important that you actually make those personal relationships, and I think an event like this, where everybody's networking and you make that connection with somebody. Although I work in IT, I would say that really the most important thing is that human connection. I also wanted to get in at this point the fact that the way that we, with a very small team, managed to do so many different projects is because we have a very structured approach to how we do it, and we have a checklist of products that we've tried and tested over time or invented ourselves, to make sure that every time we do a project we do follow the same pathway, and that helps us to be able to be clear when we're talking to our partners, but very open and honest about how we've got to where we've got to, and yeah. So I think that's also important, and one of the reasons why projects don't work is if you haven't got those structures in place. So you also need to have some sort of vision and a shared commitment to where you're trying to get to, and that's also quite hard when you're dealing with 23 different organisations, all with their own agenda. I would say that what I've learned is that there needs to be a problem to solve. It's no good just doing a project because you've got something shiny new and people are interested in it, or you've had the salesman come in and all the consultants have gone, we've got to have this now. You need a really committed person at the top, so you need a champion who's going to help you to find your way through all the different rocks and bumps and things that you're going to encounter along the way, and I would also say that people need to recognise that this does cost money. It doesn't just happen. People are often saying, well, where are the benefits? Tell me the benefits. Benefits have to be identified. They have to be monitored, and people have got to help you to uncover them. Having an interoperability programme by itself is not going to achieve the benefits at the partner organisations that they want. You need to have committed people there who are going to help to realise those benefits with you, and those people need to be part of the team. So working with Orion, we've had a journey of a relationship with Orion, and we've recently got to a place now where I would say we are like one team. So we know their strengths, they know our strengths, and we work to them. And if we find any, what my boss calls stones in the shoes, we work together to get rid of those. And we if there's anything that is irritating, we're open and honest about it, and we work together to sort it out. But also say that it does require a bit of a leap of faith. So you might have some partners thinking particularly around mental health, where sometimes the people who are looking after that information are really thinking that that is more different and special than any other sort of information. But actually, if you've got that trust between you, and they know who is going to be sharing it, that it's role-based, it's going to be looked after, you can make great strides. So last year, our mental health trust agreed to show all the crisis, contingency and relapse plans and the perinatal mental health plans in our system. And that's made a massive difference at the emergency department, where often people will turn up, and you can see people have been in there for a lot longer than 4 hours, and it's a mental health issue, but they didn't know that there was a care coordinator, they didn't know what the plan was. Now they can see that. So, to say, yesterday there was a lot of talk from Tricia about spinning plates, and I was laughing because I thought, yes, that is what it feels like sometimes, that you are really stretched and you're relying on people in other organisations to sometimes keep your plate spinning somewhere else. It can feel uncomfortable. You do have to be bold, you do have to make it happen. But I would just like to finish by saying that digital transformation and the sharing of information between organisations, I think it's the only way that we're going to be able to sustain the level of health care and social care that we're providing, and maybe even improve it. Yesterday, Shauna was talking about how people have got to radically rethink how they use their skills, and I think the same is true in this interoperability space, because it's the only way that we're going to be able to make ends meet. We've shown that it is possible. I think it's essential, and actually I think it's inevitable that people will come round to this way of working. And that's really my presentation about our Connecting Care programme.